Welcome to this edition of the Leaders in Neurosurgery series. My name is Michael Schulder. I'm a neurosurgeon. It was my honor to serve as the historian of the AANS for a number of years. And it is even a bigger honor for me and a privilege to have as our guest today, Professor Roger Stupp, who is, I dare say, the world's leading, most famous neuro-oncologist. You will all know Dr. Stupp's name from the eponymous protocol, which is now the worldwide standard for the treatment of patients with newly diagnosed high-grade gliomas. Dr. Stupp is a native of Switzerland. He went to medical school, and I'll just refer to my notes here, at the University of Zurich. Following that, he was a resident in medicine at the University of Bern in Switzerland, returned to Zurich to train in medicine and clinical immunology, and then was a fellow in hematology and oncology at the University of Chicago. After that, Dr. Stupp returned to Zurich, where he was a professor of medicine, and then moved to the University of Lausanne in the French canton in Switzerland. And he'll tell us in detail about his personal journey, among other items that we will discuss with him. It's noteworthy that in 2017, Dr. Stupp moved back to Chicago, this time to join the faculty at Northwestern University Feinberg College of Medicine, where he currently serves as professor of neurological surgery. He is indeed the Paul Busey Professor of Neurological Surgery. He is also professor in the departments of medicine and the Division of Hematology and Oncology, and a professor of neurology leading the Division of Neuro-oncology. He is also the associate director of the Lurie Cancer Institute at Northwestern University. Dr. Stupp has written and co-authored over 350 peer-reviewed publications. A small number of those early on in his career were related to other aspects of cancer, but over 330 of those papers relate to the treatment of people with brain tumors, which is really quite remarkable. What's even more remarkable is that if you look at his patient reviews on Yelp and things like that, he's a 5.0 across the board. So in addition to being truly world-renowned and an academic leader for decades in the field of neuro-oncology, he's a great doctor. That to me is the most remarkable combination. So welcome to Leaders in Neurosurgery, Dr. Roger Stupp. Just one housekeeping item. This is an item I've heard discussed with you before. Do you prefer Roger or Roger?
So first of all, thank you very much for having me. Thank you for this beautiful summary. I start blushing and so on. Now, the question of Roger or Roger is really depending in which part of my career we meet. Of course, when you are in Switzerland, where it's very French-oriented, it's Roger. But then when I moved to Chicago for my fellowship, Harvey Gollum, the chairman of the Division of Hematology Oncology, said, I can't pronounce that. And he just then said, here in the US, it's Roger. So that's why I go for both, and I'm used to both. So either one is fine.
Okay, thank you for clearing that for our audience. And could we just jump in and talk about what has become known as the Stupp Protocol and tell us the genesis of that? And please set the context for where the treatment of patients with glioblastoma and high-grade astrocytoma were before that, and what it took to get that protocol organized, bring it to completion, and how did it become a worldwide standard?
So if we go back, and as you mentioned, I'm trained as a hematologist oncologist. I was a cancer doctor, interested in lymphoma, interested in drug development, new avenues, etc. And when after fellowship, I moved back to Switzerland, and I ended up in Lausanne. Europe is more hierarchical. So nobody asked at that time, what do you want to do? Basically, you were told, you were taking as the junior whatever the other didn't want to do, among which was brain tumor treatments. were thrown in a tumor board with having had almost zero exposure during my training on brain tumors, where there was Nicolas de Tripollet and others. But we were also pioneers in working with telemedicine. So we had the two universities, University of Lausanne and University of Geneva. That's about 35 minutes away, 40 miles away, easy. So we had our tumor boards already in the late 1990s as a video system, not as sophisticated as today, but that worked. And the other thing is we had, and that was because the chairman of oncology had worked with temozolomide, and we had access to temozolomide as a drug. So that was kind of the landscape I was in. Honestly, I had no clue what a true glioblastoma was. I had no prior experience, but all of a sudden I had to take care of those patients. And I remember the first patient, not the first patient I treated, but the first patient who was then ultimately on trial was a 20-plus-year-old girl who I'm supposed to treat with radiation, and, with a life expectancy somewhere was from 9 to 12 months. And we had a little bit of experience on a clinical trial in recurrent disease with temozolomide. There was also the fact that I knew that at Newlands in the UK had actually used temozolomide continuously for up to 7 weeks. And coming from other parts of cancer, I said, okay, we had the most progress we had made in solid tumors were when we combined chemotherapy and radiation. And that's really what I learned at University of Chicago during fellowship. So we designed a protocol to do the same thing in brain tumors, did the research a little bit behind, also of the literature. Of course, when you look at the literature with an idea in mind, you're always going to find the preclinical work that would suggest that what you want to do can be done. So I found some papers that would suggest that chemo and radiation may be a good thing, even for glioblastoma. And then the question was how to do that. So we ran a trial. I had that phase 1 trial of temozolomide alone. We combined it. Plus, because I'm an oncologist and not the neurologist, 6 months of maintenance temozolomide. Why 6 months? Because that's what we have been used in adjuvant treatments of breast cancer, often in lymphoma, it was 6 months. So that was a good number in brain tumors. And we did a pilot trial. I didn't even know that there were that many patients around. Lausanne is a small university. Switzerland is a small country. But we recruited together with Geneva 64 patients. The treatment went well. Safety was confirmed. But I had reached out from day one to the EORTC to have a trial in a larger cooperative group. At the initial time, even thinking that there's no way that I can do even a pilot trial by myself because the tumor is too rare, the disease is too rare, I don't see enough patients. Now, if you want to go on the anecdotes, you come to a cooperative group, and whoever on the call know when you work with cooperative group, you learn very fast that you need to listen to your statisticians. And the statistician, Martin van Glabeke, was very clear, said, I'm not going to sanction any trial that is not randomized. You need a randomized trial. So I saw my 80 or 100 patient trial going into even a larger trial. I'm not sure how we're going to be able to do that. But I had also learned the statistician is always right. So, okay, then we do a randomized trial. And we started preparing this randomized trial while we were still recruiting in our pilot trial. And it was initially designed as a randomized phase 2 trial. And by the time when we were in a cooperative group setting, 2 years later, ready to launch our randomized phase 2 trial, there was enough data from our pilot trial out there, even though on efficacy we were not sure, but surely on safety and feasibility and recruitment, that it suggested, okay, we could actually change the statistics of our randomized phase 2 in a full-fledged phase 3 trial.
And at this point, how many years out is it since you started this journey?
Actually, only 2.5 years out. So things went very one after the other. You could not have planned it. It was because I was thinking things in parallel and looking for how I can get help.
And did you get a lot of pushback? People telling you it's not going to work. Why are you wasting your time? And who the hell are you anyway, leading a big trial like this?
I got a lot of pushback, of course. And again, neuro-oncology dominated by neurologists by training at the time. Here we are, and I had a whole room full of neuro-oncologists telling me you're crazy and late toxicity if you combine chemotherapy with radiation, which I absolutely, until today, worry about late toxicity and had sleepless nights. And anything new I do today, I worry about toxicity. And then at some point I reflected and I said, guys, if we get late toxicity, this is really sad and bad. But if we get late toxicity, that actually means that the patients have lived long enough to have late toxicity. The way we treat today, we never get to that point. And that changed the dynamic of the room, that changed the dynamic of the colleagues, how we interacted, and really helped move this forward. Recruitment afterwards was so fast that it almost break our neck because we were not ready to have several patients randomized every day. And
is that really the pace you were working at?
Yeah.
Several a day?
Yeah. I think we had, God, I always knew, I think it was 578 patients that were on that trial, if I remember correctly, something like that. I probably need to read my own paper again. And it was about 18 months recruitment.
And once the paper was published, how much promotion, if you will, did you have to do to get it to be accepted, or did it happen on its own? How many meetings did you go to present it? How much debate and again pushback was there internationally?
No, there was at that time was no pushback. The pushback was early on in the design. I did a lot of traveling while the trial was ongoing, also to convince people, gave grand rounds everywhere. So that was easy. We had in the meantime also published in 2002 in JCO our phase 2 data, which had a title which I would never allow nowadays, Promising Survival. If I would be a reviewer today, I would actually cross off the promising, don't make any conclusions, and be factual. So based on this, it was really accepted basically the day the data was out. And it was quite interesting. So temozolomide was produced at the time by Schering-Plough. And at the time, there were no late-breaking abstracts last minute. So there were late breakers, but they came out not on the day of the meeting, but they came out a week before. And I think the meeting itself started the following Friday, and the abstract book was out on Monday. And apparently, the pattern of prescription for temozolomide and the demand of different dosing has changed the day that abstract book was out.
That's fantastic. And that's now 19 years ago.
20 years ago. So
Okay.
it was. So you were asking when the presentation. This was a 2004 plenary session at ASCO, one in a lifetime experience. Speaking in front of 10,000 people, out of which 9,990 had never heard glioblastoma or anything, because as a medical oncologist, they would never have seen those patients. And I had exactly 15 minutes to pass the message. So it was quite interesting.
So, as you said, your statistician said it's got to be a randomized trial. And the RCT, the randomized clinical trial, has been a gold standard since the, let's say, post-World War II era around the world. And it's now coming under a little bit of attack. It takes too long, it's too expensive. What do you think about that? Do you think that historically that has been a good idea to have the RCT as the standard? Is it something we should adhere to or move beyond?
I think a very good question. I worry moving beyond, and I think it's still the right experiment at the right time with less beliefs and more data will move us faster forward. If you look the amount of money we waste in healthcare, the RCTs, it's not the money that is the issue. The challenge of the randomized trial is that patients feel they're getting the wrong treatment. They want something new and innovation. But we have so many things on beliefs that we are doing that are not proven, that are wrong, that they're not needed. Even on treatments we have established, is the doses we use, is the frequency we use really the one that is needed? Never proven. So I think the RCT gets us the most amount of data in the shortest amount of time. What takes time is setting up the trials, the politics behind, the research group, maybe a few committees too many to review. At some point, you got to do it rather to try to make it perfect. And things change over time. You know, you work with what you have, and our knowledge base is always has missing parts.
So, as you said, the Stupp Protocol became accepted very quickly. How are you going to argue with the facts? And they were good facts. Of course, we all, including you, would have wanted the increase in survival to be more, but that's what it is. It still was measurable and a noteworthy thing for people with glioblastoma. And yet, you were the senior author, I believe the principal investigator on the trial of Optune using Tumor Treating Fields for patients with newly diagnosed glioblastoma. And that trial has, or the results of that still, even now, years later, get pushback, and it has not been widely accepted. Why do you think that is?
I think it shows our limitation in our minds. I think we are not open enough to innovation. We're not used to use a device. This idea that you put something on your head, that you shave your head, I think it's a big problem, more of the neurologists and the neurosurgeons than of the patients. Because when we treat breast cancer with drugs that you lose not only your hair on your scalp, but all your body hair, that's even more invasive. I think there has been a lot of negative propaganda upfront, some which is clearly wrong statements. I had colleagues who would say how terrible a patient feels on Tumor Treating Field that I caught when they were saying that on a podium, that they had actually never treated a patient. And because for once the manufacturer knows who has been treating a patient or not, here we know who had prescribed it. So there is all kind of factors that has nothing to do with science, but with beliefs, with feelings, with wrong emotions. And I think, I'm an emotional person, but in science, when looking at data, you have to be kind of neutral and accept that an experiment can go one way or another. All of a sudden, everybody wanted to have more than one trial. We wanted to have a sham device. Now, the people were arguing follow-up and care was much better because the patients would be seen from the company, which is actually mainly a phone support for the electrodes. And all I can say, if better care prolongs survival by 5 to 6 months, maybe we should go back home and check what care we provide to our patients. And we have had another trial. I have done only successful trial. I've done a trial also within EORTC of silengitide, a phase 3 trial, where patients came in twice a week to the oncologist's office and to the fusion suite. And the production was at the end a hazard ratio of 1.0. There was no difference in outcome. And there was no placebo on the other arm because we felt twice a week IV is also not fair. So I think there is just a way you want to look at things. And it's true, some people just don't like it. Maybe the manufacturer's public relation was not as good than some of the big companies, but that should not be a reason to refute data we have. Do we understand all the mechanisms of action? No. Do we understand all the mechanisms of action of many other things we do? Probably no, too. So that's kind of the things. But if we backtrack for a second, we left one important part out of the temozolomide story, is that in parallel, because we had central pathology review and we collected tumor tissue blocks, we looked at tissue, we could, even though it was not pre-specified, because at the time we designed a trial that was not known, we could look at MGMT, and we had a prospective analysis with a SAP before we went in to check and test the hypothesis whether MGMT is a predictive factor. And indeed it is. But if you want, here again, the community doesn't necessarily follow the data, because the work, beautiful work done and led by Monica Heggie, showing that MGMT, almost too good to be true, is such a strong factor for who benefits from temozolomide or not. We are 20 years later, and standard of care is still temozolomide for all the patients, because we don't have something better for the others. And we as doctors don't have the guts to tell the patient it's really bad. It's not only bad, it's really bad. And I think all I can offer you is Prozac, and I'll give you 10 milligrams because I need 20 for me to even stay in the job. So,
but as a result of that follow-up study, you now have neurosurgeons everywhere talking about molecular genetics, IDH, MGMT. These are things that traditionally neurosurgeons would have really no knowledge of or any fluency in, and now it's become part of the regular conversation, which I think is remarkable. But I mean, you haven't been around that long, but could you maybe give some historical perspective to our audience? Because there are a lot of nihilists amongst neurosurgeons, not just, but amongst neurosurgeons. Well, nothing works for glioblastoma. Could you sort of explain to people how the landscape of treating cancer in general has changed in the last 40 years, starting with hematopoietic cancers and now on through solid cancers?
Well, the field has tremendously changed. When I was starting, there were a few crazy pioneers. Many hospitals didn't have a separate oncology department. It was an internist some would look more about lung diseases, pulmonologists, and there were some oncologists, but you would still do general internal medicine. We have increased survival, not only in brain tumors, but in all solid tumors, and we're curing more and more, lymphoma, hematopoietic cancers, leukemias have better treatments. And they led the way of also integrating molecular knowledge into daily practice. Now, they have one advantage. Getting tissue of a liquid cancer repeatedly is a blood draw, while for us it is a biopsy. So there has been tremendous progress. So there was a decade of angiogenesis around the 2000s, and the last 10 years, it's immunotherapy that has completely changed the landscape. Again, far from what we understand. It doesn't yet work in brain cancer, but we have a lot of work we are doing and to overcome that. There is challenges particular to brain tumors with the blood-brain barrier that we have not adequately considered. So many of our trials we have done have been somewhat naive, thinking, oh, the drug will get to the tissue, but it doesn't, or not sufficient. We never went there to actually check it. So again, temozolomide was completely different. This is a designer drug, alkylating agents, in the 1980s, 1990s, by a medicinal chemist who on purpose developed an agent that would cross the blood-brain barrier. And we could probably have done it with other drugs if we had them used a little better, or had drugs with better blood-brain barrier penetration. So there is hope. I have many patients with glioblastoma now that I follow for years. And just for your audience, just look how many neuro-oncologists you have now in your respective departments. And at the time at University of Chicago, we didn't have maybe one or half, but there were none. And one, it's not because the disease is more frequent, but we are aware of it, we do more, and patients live twice as long or even more than twice as long. So you double your patient bases automatically just by that.
Is it fair to say that you will miss 100% of the shots you don't take, and that the only guarantee of failure is to not try?
I think perfectly said.
So you did train in Chicago. You returned to Switzerland, and then after really 23 spectacularly successful years, you returned to Chicago, albeit to a different institution, of course, a world-class institution as well, Northwestern. But what made you come back to the US?
This was a crazy phone call from the chairman of Neurosurgery, Matt Lesniak, who I had never met before, but we had correspondent and we knew of each other's research, who sends me a text message on a Saturday. I just came home, and for me, it was already middle of the night, and I wanted to know more. So I replied, and then we talked. And I told him, are you out of your mind? I'm chair in Switzerland. I'm comfortable. But it was still intriguing. I said, come nevertheless. Now, back to Chicago, where I had some of the best years, where I had the best possible training, outstanding training I got at University of Chicago, even though it wasn't in brain tumors. I learned all the tools that it takes to afterwards build something. I said, that was inviting. So I said, okay, come for a week. I spent a week here, and I was somewhat tired and unhappy with chairmanship, budgets, human resource issues, territorial fights. Why not come back to Chicago? I never wanted to leave Chicago, but at the time, with a J1 visa, I had no choice. So it was a complete different experience. Now they wanted me. I didn't have to beg for the visa. They would come. And I never regretted it.
Roger, people all over the US are thinking after you went to Northwestern, damn it, why didn't I think of calling him? But Chicago in particular had a pull for you because you had lived there?
Yeah.
Can you tell us about your perspectives on Swiss versus American medicine? We all think of Switzerland as a country of great efficiency and prosperity and peace, and everything kind of works there. And America is a big mess, and in particular, American medicine gets bad press. So what's your perspective on that?
God, you're asking all these difficult questions today. I think it's way more similar than you think. But everything is a little bigger and greater in the United States. So also the nonsense sometimes, the number of committees. We're getting so big. Who is going to dialogue? We are very siloed. When it comes to patient care, surely the fact that not every patient has insurance, not every patient has access, while in a more social system, it's not a socialistic system, but everybody has health insurance, at least covers the basis. That's quite different, that you can't get certain things done. The number of useless approvals from insurance companies, when actually the drug is approved, it's even in line, that I have to justify either I'm the expert on the field or not, just to avoid that some of our colleagues abuse the system occasionally. I think that's in our way and takes a lot of efforts and consumes a lot of money. Another difference, also in a good way, is the US. This yes, we can overcome. We push for more. A clinical trial here is actually a good thing for a patient. They want it. That's why there are so many. Not all are always actually worth doing it, but that's what the demand is. While in Europe, I would have to tell the patient, you're not the guinea pig. I still try to treat you the best way I can. It takes a little more convincing. Where maybe one difference is we have a little easier to sometimes explain that yes, we can and overcome everything is true, but not always. And that there is also time to do less, focus on the quality of life, and that certain things we can not control in our lives and in our world. So that's another little difference. But that would give a whole different philosophical excursion, what we can do, what is wrong in the medical system everywhere, and where we will be going.
A little bit along the same lines, in the 19th century, Americans traveled to Europe, really to Western Europe, to study medicine, including Harvey Cushing, who did that around the year 1900 after finishing his residency in general surgery. By the time Cushing retired in 1932, Europeans were coming to the US to study medicine. And the US is still, to a large extent, the world center for medical research, for medical training, state-of-the-art treatments, etc. Not exclusively, but again, to a large extent. Is this a trend you think that's under threat? And what should we in the US do to maintain it? Should we try to maintain it?
I think the pull to the US is less than it was for my generation. And I see more people who have never left their countries, especially from Europe. For the Far East, it's different. I think it's an absolute must that people should have when they want to move forward, to come to the US, to see the system, to get that drive for research, that yes, we can overcome being translational, to have it experienced. You need that. You need to see both worlds. And I had the privilege to come here in young years, got the opportunity to be 3 years at the University of Chicago, and could then marry kind of the two backgrounds. When I'm here, I'm usually always the European, but after my training in the US, in Europe, in Switzerland, I was always considered the American, that they don't fully understood, and sometimes was difficult to integrate because the ideas would go faster than for the rest of my colleagues.
So, lastly, what would you tell a young aspiring medical student or neurosurgical trainee or resident about going into specialized in brain tumor treatment? As a surgeon, as a scientist, there's a lot of push for young aspiring neurosurgeons to, let's say, go into fields that are somewhat easier, into spine surgery, into endovascular. Perception is it's easier to get a job when you're done with your training. The results are better. The patients are less sick. What's your advice and perspective on that?
It's a question of temperament. As long as if they're passionate about it, I never felt it hard. I never felt it the wrong decision. The same is true on the neurosurgical side. What I would tell the young ones, especially if you want to go into tumors, research is an integral part of being a cancer doctor, whether it's a surgical cancer doctor, a medical cancer doctor, a neurological cancer doctor. Integrate that. If it is only seeing patients from morning to evening with no perspective, then you're going to get worn out. Burnout is on the horizon. But if you combine it, we have beautiful physician scientists here in Chicago, Adam Sonnabend, who does all the work with the blood-brain barrier opening and using ultrasound. but many others, Amy Heimberger, on the immunological front. We have scientists, pure scientists, and also pure clinicians, but they would interact and work together. So there is plenty of possibilities. I think I complain, yes, it's the best job I ever had. Wouldn't want to have another one. I think that's, and then if you're passionate, forget the hours. And I still had a great work-life balance, and my life was also my work. So I didn't need to separate all the two. I think I could only encourage. Now, some people are interested in the vascular or in the spine, or want to have a different surgical skill set that they want to develop. Fair enough.
Well, Dr. Roger Stupp, thank you for your perspective, for telling us about your personal history in treating patients with brain tumors and the history over the last several decades. And I really salute you for your accomplishments and your passion, as you talked about the importance of passion, and you're setting such an amazing example for all doctors, patients' families, and particular for neurosurgeons. And thank you again for participating in the Leaders in Neurosurgery series. And thank you, audience, for watching. And we hope you found this to be informative and inspiring, and certainly I did as well. Thanks to everyone.
Thank you so much for having me.